There are two keys to solving healthcare. One, drive down costs, and two, make both healthcare and health insurance more accessible. While the ACA addressed in part accessibility, the manner in which it made health insurance more accessible actually made healthcare less accessible. We all remember the if you want to keep your doctor, you can keep your doctor debacle. And as we have already discussed, the ACA did very little to actually drive down the cost of healthcare, which had and still to this day has the greatest impact on the cost of health insurance. To address healthcare as a whole, we must drive down the actual cost of accessing healthcare. This is the driver of all parts, both accessibility and health insurance premiums. If we don't start with the cost, everything else is in vain. We have broken these solutions into 10 parts and made some assumptions about the current pieces of legislation that attempt to address healthcare. We also recognize that the following is just an outline of some of the many parts of healthcare. And while we have spent countless hours researching each of these things we will discuss, we also recognize that there is much more to the healthcare system than these parts. However, these things are what we in our industry call the big rocks of the healthcare system. And if we are able to move them, the smaller rocks will be easier to address. Our solutions will address the two key areas we have already touched on, first addressing the cost of healthcare, and then addressing accessibility. Earlier, I commented on the Affordable Care Act and stated that it had many commendable parts. It's not that the ACA didn't address some very obvious problems, it's just that it focused on those problems primarily in one area, that was health insurance. The ACA has also become a political football with half the country supporting it and the other half opposing it. So since we're all divided on this, let's begin with this fact. The Affordable Care Act is the law of the land. Sure, it was passed along a party line vote, but it was passed nonetheless. And while the Republicans have proposed a replacement bill, the other fact is this, that the Affordable Care Act cannot be fully repealed without a vote that would include both Democrats and Republicans. The Republicans in Congress can only partially repeal the ACA through a process of budgetary reconciliation. So, regardless of the rhetoric, the ACA is here to stay, at least in some part. Now that we've addressed that, we would suggest that instead of trying to partially repeal it, instead, let's repair it. I know that I've alienated about half the country with that statement, but politics aside, let's address problems, not use them for political gain. The reality is that many aspects of the Affordable Care Act were both in the original bill and are also in the Republican replacement bill. Why instead can't we just give both sides a win and allow Democrats to keep the ACA, but allow the Republicans to usher in some aspects to repair it? I recognize that this may not be a good political move on the surface, but I believe that real solutions are always better than partial ones and that those partial ones ultimately won't have an impact. We can fix the ACA and allow it to do more. We don't have to repeal it, and in keeping it, we just might find both sides of the political aisle winning. The most important thing to address when attempting to solve the cost of healthcare is transparency. The healthcare system is extremely difficult to navigate. This is intended, I believe, as it allows the delivery system and the finance system to increase their profits year over year. While there are obvious incentives for consumers to be more prudent in their evaluation of how and where they seek care, patients are limited in the cost and the quality of care information that they can obtain. This limitation creates confusion and thwarts competition, which ultimately results in increased costs and profits for both the delivery and the finance systems. There are three key areas of focus that we feel would better be served with more transparency. The first is in providers and facilities. Outside of healthcare, we as Americans have the ability to shop for whatever we consider to be the best deal. We can base that decision on the cost of that which we are purchasing, the value of that which we are buying, or the way in which we experience the purchase. For example, I can go do my grocery shopping at a local supermarket, at a Walmart, or at another national chain and come out of one of these stores with really similar groceries. But where I buy them may determine the cost, the convenience, or even in some cases the quality, but it's my decision to make nonetheless, and I can do so in an informed way. The same applies when purchasing things like cars, electronics, or even clothing from a variety of stores. I'm able to know the experience I'm going to have because I'm able to research those places of where I will be the consumer. Unfortunately, today's healthcare system does not provide the basic consumer with these imperative, informative uh, pieces, leaving a patient limited in their ability to shop based on price, quality, or experience. And as is often the case in the healthcare system, the consumer often doesn't even know what the cost of what they are getting is until long after the procedure has been performed. In reference to providers and facilities, we would propose that all medical facilities and providers have a standard transparency database that is published clearly for their consumers to review prior to services being rendered. This will encourage competition within the healthcare space and allow patients to see the costs of what they're getting so that they can make more informed and educated decisions about how and where they will receive care. The second area of transparency to address is within insurance network discounts. Along the same lines as provider and facility transparency, there should also be a clear understanding of the network discounts being provided by the various insurance companies. We often hear that one insurance company will have greater discounts than another. I will usually question these statements by asking, discounts based on what? Within the model that we currently have, each provider and facility will discount their standard fee-for-service charges based on their specific network contract with an insurance company. The problem with this is that oftentimes we find the standard fee that they use to base these discounts will vary from one insurance company to the next, making these discounts difficult to comprehend and even harder to quantify. With regards to network discounts, we would propose that all providers and facilities set a published base rate prior to any insurance discounts being applied. This base rate must be the same for each specific procedure, regardless of the insurance company. From that common standard, insurance company discounts can be applied based on that specific provider and facility contract. All discounts must also be published for review so that the consumer can decide which insurance company will offer them the best discounts for the services they expect to receive. The third area of transparency is within the prescription drug market and how they determine the average wholesale price, or AWP, of a drug. Prescription drugs will equate to roughly 10% of all healthcare spending in the United States, and with the continued development of high-cost drugs, that number will only continue to rise over the next 10 years. While advances in medications are prevalent to the success of the U.S. healthcare system, the means by which drugs are distributed has created significant costs to the average consumer. Large pharmacy managers, also known as PBMs, operate their pricing through a method based off of the average wholesale price, or AWP, which refers to the average price in which drugs are purchased at the wholesale level prior to their distribution to the public. The problem with this method is that there's limited regulation and oversight, which allows the AWP to be reestablished each time a new party is involved in that drug's distribution. For example, if a PBM purchases a drug from a manufacturer at one AWP, they can then repackage it at a higher cost AWP and then distribute to a pharmacy who can just do the same thing. In the end, the original cost is significantly inflated, offering massive profits and kickbacks to all parties involved throughout the process of the drug getting to its final destination. With regards to the distribution of prescription and AWP, we would propose that prescription benefit managers publish a list of all parties involved in the distribution of that drug and be limited on their markup based on the original AWP in which each drug was originally purchased. In regards to transparency, we believe that these three key areas that we've addressed will allow for better consumerism, more competition, and result in lower overall cost of accessing healthcare. A recent study in the National Review showed that by implementing transparency rules within the U.S. healthcare system, we would reduce costs by more than $100 billion over the next decade. If we want to get serious about driving down healthcare costs, transparency is the first key to doing so. Emergency rooms have become the profit center for the healthcare systems. Oftentimes, this is caused because patients enter into these facilities in pain, looking for any solution to solve it. In some cases, Patients aren't even aware of the treatment they are receiving due to their incapacitated state. Unfortunately, the healthcare systems have taken advantage of this, running up the charges within these facilities. While it's understandable that in emergency situations, facilities be diligent in the treatment of these patients, the fear of not being thorough combined with the drive to increase revenue has resulted in the average cost of an emergency room visit in the United States rising to be over $1,200. We would propose that new regulations remove either the fee-for-service model in which emergency facilities practice or limit those facilities to accepting reimbursements at a rate of 120% of Medicare. This reference-based pricing model will provide more protection for the patient while still allowing the emergency facility to be reimbursed at a reasonable rate for the services they render. A recent development in the healthcare delivery system is this method of having providers practicing out of network within an in-network facility. This is often seen in specialty areas of practice such as anesthesiology, radiology, pathology, and even surgery. The most common area of out-of-network practice within an in-network facility is found in the emergency room. More and more ERs are staffing their facilities with out-of-network doctors. Unfortunately for patients, this is not disclosed until long after treatment has been rendered, leaving those patients with extensive balanced billing and charges. We would propose that all facilities operate on what we are calling the Three Musketeers rule, effectively saying that if one aspect of the treatment is in network, then all aspects must also be billed that way as well. No longer can the cost to patients be driven up by the undisclosed practice of accessing out-of-network care within an in-network facility. A few years ago, the healthcare market began seeing a shift where large healthcare systems began purchasing primary care practices. The gateway to care is the primary care physician. Most Americans look to their PCP to provide them quality counsel and advice. Too often, primary care physicians have become the sales force for large healthcare systems, being encouraged and sometimes even influenced to refer their patients within that healthcare system for additional tests and care. This has created a lack of competitive pricing and increased expenditures for patients who might otherwise seek lower cost alternatives or be directed more efficiently by their primary care physician. The United States has had long-standing antitrust laws, but these seem to not apply to healthcare systems owning a market share of healthcare providers. With regards to primary care, we would propose that a healthcare system be restricted from owning no more than 5% of the PCP population within any geographic market. This will provide primary care physicians with the ability to make decisions in the best interest of their patients without outside influence, thus allowing for more competition and lower cost. Americans should be rewarded for being responsible and prudent. We have stated that most Americans live paycheck to paycheck, and even those that are eligible to contribute to a health savings account are unable to do so given their inability to set aside money for this. In addition, to be eligible to enroll in a health savings account, one must be enrolled in a qualified health plan under the law, which includes a high deductible. Furthermore, under current tax law, for an American citizen to be able to deduct the cost of their health insurance premiums, they must either be enrolled in an employer-based Section 125 plan or have medical expenses that exceed 10% of their adjusted gross income. If we're mandating that all citizens have health insurance, we should allow for those premiums to be tax deductible regardless of where they get their insurance or based on the totality of their annual healthcare expenditures. We would propose that all health insurance premiums paid by any U.S. citizen be tax deductible. Furthermore, we would propose that all Americans have the ability to open a tax-free health savings account regardless of the qualified status of their plan. We firmly believe that the solutions that we have proposed thus far will significantly impact the overall cost of healthcare. Now that we've addressed cost, let's talk about accessibility. We must hold ourselves accountable for consistent enrollment within a health insurance policy. We can't buy insurance for the house after it's already on fire, and we can't reasonably expect a health insurance company to bear the brunt of the billing after I've already fallen down the stairs. Additionally, in the same way that a fire department can't decide not to come put out a fire at your house, the insurance companies should not be allowed to decline coverage just because it's going to be expensive for them. If you've maintained health insurance, then it rightly ought to be honored. With regards to guarantee issue and pre-existing conditions, we would propose that everyone be offered the ability to obtain insurance by a specific date each year. Should one forfeit that ability for a period of up to 12 months, a condition could be excluded from coverage due to a pre-existing condition, or a rider could be purchased for those 12 months, covering up to 80% of that condition after the normal deductible. The rider could cost no more than 100% of the original policy premium. Yes, if you forgo health insurance and roll the dice, you could pay up to 200% of the original cost of purchasing health insurance for up to a 12-month period if you are deemed to have a pre-existing condition and want it covered. We would also propose that the allowable gap for no coverage be up to 3 months, with a 6-month exclusion for those who are unable to find employment. This protects those that lose their job but are unable to find work and then have to decide whether to put food on the table or purchase health insurance. We have stated that based on a recent study, roughly half of the U.S. population gets their health insurance from their employer. While the Affordable Care Act's employer mandate was unpopular, it really only impacted employers with more than 50 full-time equivalent employees, 95% of which were already offering health insurance prior to the ACA going into effect. The other provision of the ACA, which had significant impact on the employer market, was the definition of a full-time employee being mandated at 30 hours. The unintended consequence of this provision of the ACA was that many employees' hours were cut to keep them below the 30-hour mark, and many employers attempted not to hire based on their need just to keep their total employee count under 50 employees. We would propose that the existing employer mandate be adjusted, raising the full-time status requirement to 40 hours per week. Furthermore, we would propose that the employer mandate only apply to employers with more than 100 full-time equivalent employees, virtually all of which provided health insurance prior to the Affordable Care Act. We have previously stated that in a recent study, it showed that less than 3% of Americans get their health insurance through the individual marketplace. As a result of the Affordable Care Act, more and more private insurance companies are pulling out of geographic markets throughout the United States due to cost and lack of profits, leaving many areas with one or two, or even in some cases, no options for individual coverage. Given that so few citizens obtain their health insurance through this market, and insurance companies are reluctant to even offer policies to individuals, it's time to allow for additional competition. We would propose that the barriers prohibiting insurance companies to sell their products across state lines be lifted. Furthermore, we would propose that a public option backed by the United States government be established to offer basic, high-deductible plans within the individual market. These two changes will allow more regional individual carriers to expand their market share as well as influence competition. By offering a public option, all citizens will be provided with at least a government-based market in which to purchase their insurance. Since preventative care is key to controlling costs, both the public option as well as the private insurers can set their premiums based on a requirement of annual preventative care as recommended by the U.S. Preventative Care Task Force. This standard will allow insurers, both public and private, to increase their base premiums by up to 100% for insureds who fail to complete their recommended preventative care treatments. I recognize that using the words universal and coverage in the same sentence can be taboo to half of the political world. But in a society as great as ours, shouldn't we be sure that all children have access to quality health care and health insurance? In 1965, President Johnson signed into law H.R. 6675, ushering in Medicare. In the United States, we continue to offer access to quality care for persons over a certain age. Shouldn't we do the same thing for persons under a certain age? Children whose parents either can't or won't purchase health insurance don't have a choice in the matter. Due to labor laws, it's not as if a child can go out and get a job to obtain their own health insurance. Last year, my wife and I experienced one of the greatest scares of our lives. Our youngest daughter, at 9 weeks old, contracted an illness that, in effect, made it impossible for her to breathe on her own. As we sat in the hospital for more than 5 days, watching as machines worked to keep her breathing, the absolute last thing on my mind was health insurance and cost. All I cared about in that moment was that my little girl would stay alive. By the time we left the hospital, we had racked up a total bill of more than $100,000. I will forever be grateful to the team of doctors and nurses that worked around the clock to ensure our daughter's recovery, and would gladly do whatever it took to pay that six-figure bill. But I'm fortunate that we had the means to obtain a good health insurance policy that covered nearly all of the expenses. Some children, however, they're not as fortunate to have the insurance coverage that my Arabella had, but they shouldn't have a different end result. We are one of the greatest world powers, and as a society make financial decisions as to the well-being of our citizens. This is one decision of which we should all be in favor of. We would propose that the Medicare system, which is offered to all persons over the age of 65, be extended to all children under the age of 18. There are approximately 74 million children under the age of 18 in the United States, half of which are already covered by the Medicaid program, according to Medicaid.gov. A 2014 study performed by the Healthcare Cost Institute showed that the total cost per capita for a child's healthcare per year was $2,660. Based on these numbers, the United States could cover all children for $94 billion more than we are already spending to cover half the children under the age of 18 via Medicaid. By extending coverage to all children, not only do we ensure that they would receive access to care, but we would also remove a significant burden on U.S. families by forcing many to decide between health insurance and a quality of life. While we recognize that $94 billion is a significant number, to put that into perspective, we could cover all the children in the United States for roughly 2% of the federal budget. And that's based on today's healthcare costs. Throughout this piece, we've already presented multiple ideas to reduce the cost of healthcare in the United States, and based on our prior solutions, would anticipate that $94 billion number will be drastically reduced. In summary, there's no silver bullet or bullets to solving the healthcare problem in the United States, but while there's no easy solution, that doesn't mean that we can't work towards one that might be more difficult, but achievable. We must all give in areas that we may be uncomfortable to solve this crisis. It is our hope that the recommendations that we have laid out in this piece will be considered in the process, as we firmly believe that these are necessary steps to curbing the trend in which we are currently headed. While our team is a small group of people, we are committed to changing the world, and who knows, we just might do it. In a prior piece, I quoted Dr. Henry Foster, who, in a conversation with me, made the statement that Americans will almost always do the right thing so long as they've tried all the wrong things first. For too long, we've been trying the wrong things. The right things can be done, and it's time we begin doing them.